It's the 7-Minute Drill, a fast-paced and fun conversation about common orthopedic topics and solutions with Dr. John Urse. Brought to you by
Ted's Authentic Greek Salad Dressing and Marinade. It's healthy, gluten-free, and delicious. You can find Ted's in Dayton, Ohio at Dorothy Lane Markets, Health Foods Unlimited, and Dots Markets. That's Ted's Authentic Greek Dressing and Marinade. Thanks, Ted.
We would also like to thank
Stifel's GWR Group combines more than 65 years of experience helping high net worth clients consolidate, coordinate, and simplify their wealth planning strategies. The group has access to a full suite of resources to serve all of your financial needs. Email gwrgroup at stifel.com or call 937-353-2863 to speak to Guy, Brad, or Jeff Richardson. Stifel, Nicholas & Company, Incorporated.
Hello, folks. Welcome to 7-Minute Drill with Dr. John Urse. I'm Terry O'Brien, the producer. Dr. John, welcome.
Thanks, Terry. How are you doing today?
Who's this guy?
Well, we got Dr. Chuck Mehlman. He's a emeritus professor from Cincinnati Children's here in Ohio. Chuck's been here before. We talked about some children's growth plate injuries on a previous podcast, so he's back for a cameo appearance for today's topic, which is
scoliosis.
It's good to be back.
By the way, would you look to the camera, tip your hat, and go, howdy, ma'am?
Howdy, ma'am.
I would like to give you a little qualifications for Dr. Chuck. He's a board-certified orthopedic surgeon, fellowship trained in pediatric orthopedic surgery. He also has a master's of public health from Harvard, and he's got a lot of letters after his name, so that usually means he knows quite a bit.
A lot of letters after his name. Okay, so if we're talking about scoliosis, first off, let me admit that I thought scoliosis was for old people. But we're not here to talk about that issue. We're here to talk about kids.
You're correct, Terry. Older folks can get scoliosis also, but it's a different form. In some cases, they might have had it as a kid and it persisted into their later years.
Right.
But for folks where it just shows up much later in life, that's usually due to osteoporosis, and it's much more hunching and kyphosis, or sometimes post-traumatic, deformity where they have a fracture or something. So we're not talking about that. We're talking about adolescent idiopathic scoliosis, because that's the most common type of scoliosis that kids get.
All right.
All right. So I'm going to, we got long doctor words in there, so I'm going to cut through some of those.
Go ahead.
So kyphosis means forward bending. Scoliosis will be kind of a side bend of the spine. So think of a dollar sign, some of the curvature of the spine in a sideways fashion. It can be to the right or left.
Right.
Some of the x-rays tell you that. As he was saying, if one of the bones in the column, we talked about how the backbones are like little blocks. Sometimes with osteoporosis, bones are soft. They crumble like a little pie. That makes that segment bend forward, like the Leaning Tower of Pisa, right? So we're not talking about forward bending, hunched over patients. We're talking about more scoliosis, which is curvature. The last thing he mentioned, too, is another long word, was idiopathic, and that's a Latin word for I don't know what the heck caused it. So it's, but idiopathic is just a type of thing that occurs, and we treat it, but we're not always sure why it happens. But there are other reasons people get scoliosis that he may allude to.
All right, so tell me a little bit.
This is some of that side. This is some of that side action that Dr.
That's a pretty crooked
about.
Spine to me.
Okay, and that's an extreme version of it. From our alma mater, by the way, down at the Ohio University, but that's how bad it can get if left completely untreated.
That's amazing. Did that person? I mean, how old was that person? You think?
That person succumbed to their disease later in life.
Okay, so is that common in children, or not common in children, but mostly in children we're talking about today, right?
Correct, but to back up for just 1 second, left untreated, it is a dangerous disease that can shorten someone's life. It puts abnormal pressure on your heart and lungs, and that is not good. It's one of the rare things that can cause right-sided heart failure, which is a bad thing and will shorten your life.
Wow. All right.
So that's why we're going to talk about, when growth spurts occur. Growth makes us taller if it's in what's called a long bone. But in the spine, if the growth occurs in a curved direction, then we're going to want to see how old the person is when this growth is starting. We're going to ask Dr. Mehlman to say, is this a very mild form of scoliosis? Is this a more severe form? How much more growth do they have? And how do we tell how much growth someone has? And when do people get these growth spurts that are being analyzed by either x-rays or some of the historical information?
Yeah, so when do you first see it? What age do you first start to see this?
And so it's into the, as Dr. Urse alludes to, it's into the rapid growth period. And that's the classic situation for adolescent idiopathic scoliosis. Scoliosis is very much a genetic disease. All of the simple single gene things have basically been worked out, and what's left is complicated multi-gene abnormalities like scoliosis. A bunch of those genes are on the X chromosome, because girls, of course, get two X's, and a boy gets an X and a Y. And so scoliosis that needs treated is much more common in girls than boys, but boys can get it.
Really?
Yeah, almost totally. It is often portrayed and discussed as a women's health issue. It's like the opposite of coronary artery disease. There's all sorts of studies and all sorts of data on older men with coronary artery disease and comparatively few for women.
Right.
And in scoliosis, there's a ton of information about girls with scoliosis. And as I like to point out, there's like 2 papers ever written about boys with scoliosis. And in both of those, the lead author was one of my former colleagues, a female pediatric orthopedic surgeon. So that's the roots of scoliosis are genetic. And when it comes down to screening for it, checking as to when it's going to show up, there's some actually very good criteria for doing that. This is a rare case where not one, but 4 different organizations agreed on what the criteria should be for when to screen for these kids. The American Academy of Pediatrics is a big, powerful organization of those primary care doctors. The Pediatric Orthopedic Society is the most important society to me. The American Academy of Orthopedic Surgeons as well. And then also the Scoliosis Research Society. I don't think you could find another thing in medicine where 4 large organizations agreed on how to screen for something.
But is it really common? I mean,
Well, can you tell people how screening can occur? Because it goes into the schools sometimes, right? The
Correct.
nurses in the schools literally sometimes are the first people. Let's face it, if you're a father with a young girl who's getting her maturity with her growth, you may not be watching her dress. You may not be seeing her, her spine.
Yeah. Right.
So it may go unnoticed. I've seen some bad scoliosis in doctors' kids.
Yep, absolutely. I make the same point. I said you go from giving your kids a bath naked in the sink to the bathtub at the house to get out of my room, so you don't see your kids like you used to. So to Terry's point, it's common enough that we need to check for it routinely. Scoliosis that needs treated is about a 1 in 1,000 sort of disease.
Yeah.
Is
it hereditary?
Very much, and that's where it comes back to the genetics. Where if a girl was, it demonstrates a specific type of genetic inheritance pattern that is referred to as the Carter effect. And the Carter effect states that there's sexual discrimination when it comes to the disease. And well, that doesn't sound fair. And what that means is it's easier for a girl to get it and harder for a boy. But if a boy gets it, it's easier for them to pass it on to the next generation. So that's the little snippet.
All right.
Now, when it comes to the screening that you talked about, for girls, by the time they're in the 5th and the 7th grade is when the primary care doctor, the school nurse, if they have a functioning school nurse, can bend them over and screen what's called the Adams forward bending test. They put their hands forward like they're diving in the water and bend over. If you see a prominence on their ribs, you become suspicious, and they might need to be referred in for an X-ray.
It sounds silly, but it's literally a rib prominence would be almost, if you think of a hump on an elephant or even like Marty Feldman on Young Frankenstein, but like, which he changed from side to side, by the way.
What brain did you get?
That's right.
Normal.
That's right. But the nurses are looking for just major gross abnormalities that, like, this is not a normal looking back. And they look at a lot. Then they say, I'm screening this and saying, let's send us over to Dr. Mehlman. And is there anything here? He'll do the next set, which is the exam and some of the x-rays.
But is there any other symptoms they might exhibit other than you see something when you're doing that test?
None.
And isn't that interesting that you asked that? Because painful scoliosis can be a little more of a problem. Is that right?
It's much more concerning, especially if there's night pain, et cetera. But classically, as Dr. Urse correctly states, scoliosis is not considered to be painful. If there's a significant pain complaint, that gets our attention even further, and there may become a need for other evaluations beyond your physical exam and regular x-rays, MRI as an example. So for the girls, I like to say I'm a hopeless mnemonic and memory tool person. So 57 Chevy. 57 Chevy there's a sweet girl, pinup girl here from the old days on the calendar. 57, she's modeling in front of the 57 Chevy.
Yeah.
So 57 Chevy means that if it's a girl, 5th and 7th grade. Why do girls get screened twice? Because they have the disease more frequently than boys.
Okay. So
Boys-
1 in 1,000. So if I go into a high school that has 1,000 kids, one of those girls may have scoliosis.
At least. Yes, sir.
Okay.
And now, because of differences between how boys and girls grow, those 4 organizations agreed that boys should also be screened, but a bit later, because as I also like to point out, through the entire life spectrum, women are ahead of men. All from the beginning to the end, just admit it, come to terms with it.
The sooner the better.
And so boys should be screened in the 8th or the 9th grade. And believe it or not, there's a book that Lewis Carroll wrote that's called 8 or 9 Wise Words about letter writing. And so that's my memory tool for boys to be 8th or 9th grade.
Same
Can't
test?
live in Alice
Same
in Wonderland forever.
He couldn't
To write
live
other things. Pay some bills.
So that's the rate of scoliosis. That's some of the genetics roots. And those are some of the most appropriate, that's the agreed upon times to screen kids. Now, a lot of schools, not every school has one school nurse to just look after that school. Many school nurses are frazzled. They have to cover a bunch of places.
Right.
Some places have given up on school screening. And so just for all the kids to be screened together, or even at the primary care doctor for them to screen all the kids.
When a primary care doctor usually look for that, say, okay, they're coming in. It only takes.
We hope.
We
It only
hope
takes
so.
a couple seconds, right?
Correct, but you know, everybody's busy and everybody's not all. You know, that which falls within your training and experience and
Yeah.
how you were, what you saw, you know, growing up through your residency, et cetera. So it's not routine.
So as parents are listening out there, we hope this is something they could do. They could actually.
Absolutely, and many times it is the parent, especially as we get into warmer months and the child, you know, it's mostly girls, and they're putting on their bikini and they see asymmetry of their waist, where they're shifting one way or the other.
Yeah.
They see big differences in shoulder
The
height,
leg length might be uneven.
and so the
things like
parents
that.
deserve a lot of credit for picking up on it as well.
Okay. Well, that's,
So tell us what we're going to do now. We've got a little red flag, school nurse, parent, pediatrician. Someone says, we better get him over and talk to Chuck. So what are you going to do in the office? You're going to do an exam. You're going to do some x-rays. How do we tell nothing to worry about versus, hey, we got to worry about this case?
So the physical examination reigns supreme, and your screening neurologic exam, maybe the single most important neurologic test we could do is to have kids walk and run up and down a long hallway in clinic. And when they pass all of those tests with flying colors, which is usually the case, and there's no complaints of pain, like we touched on, then we repeat the Adams forward bending test, decide where the rib hump, if there's a rib prominence on one side versus the other, if there's prominence in the lower lumbar area and the lumbar paravertebral muscles. And we check a variety of reflexes top to bottom. And then we get to the x-ray. The x-ray, in a new scoliosis, we get both the front view, which we would refer to as the AP view, it's pretty much your coronal view, to use the phrase, and then the side view is the lateral. We don't do both views every time because we don't need both views every time to
Right.
make decisions, and we do that to, of course, minimize x-ray exposure.
okay.
But then we got to measure something, right? So we got to get out the old little math skills you had as a child and get out our goniometers, and we look at the angle of curvature.
Yeah.
And there's some bad actors and then some nothing to worry about mom patients, right?
We pick the levels that count, the ones with the most tilt at the top and the ones with the most tilt at the bottom. And I overstate it slightly and call it the only application I know of alternate interior angles in modern medicine. Now, in reality, it's referred to as the Cobb angle. That has nothing to do with corn on the cob, but John Cobb, a scoliologist from upstate New York from back in the day, and that's how we measure. And lots of people always want to say percent. Oh, my daughter has 30%, and we just politely correct them. We said, no, it's 30 degrees. Is what we
30
just
degrees.
measured.
Okay.
30 degrees. So it gets measured in degrees. And then the other truth of the matter is there's a bunch of scoliosis where it is a smaller curve, and it doesn't demand treatment. I say the amazing thing is if you count up your neck bones, your thoracic, and you count them up, there's 25 things that stack on top of each other, and it's amazing that it stays straight as much as it does. It's a magic.
You're talking about the C9, the C8, all those little C's.
Exactly.
That you
Just
The
as you
C's,
see
T's,
seven.
and L's.
Exactly.
Just
T's
from
and
top
L's.
to bottom, and what if you have a little bit, you need someone like him to say, look, your daughter's got 5 or 10 degrees of a little slight curve. This is nothing to worry about. We call them nothing burgers because there's nothing to worry about. But someone's already told him, oh my goodness, my daughter's got this.
Yep.
So there's some very never going to bother you ranges of a degree of scoliosis curvature.
Yep.
And then there's some where, little Cindy, she's got the little retainer in. She's just starting her growth spurt. And how do we tell like how much growth a child has at certain ages.
Yeah, that's the question. If all of a sudden your child goes through a really big growth spurt, is that like something
He
I
thought
should be
you'd
worried
never
about?
ask that
So
question.
you guys are both nailing. You're both nailing the head, hitting the nail right on the head. You're at biggest risk of any scoliosis that you may, any tendency you have to have scoliosis. It's at biggest risk to get bigger when you have the most growth. So for girls, we have this thing referred to as their menstrual periods. And that is I always apologize to families. I say we are prying into some private business here, but there's a reason behind this. And when a girl is premenarchal, has not started her periods yet, and there's significant scoliosis, that one's at very high risk. Once a girl has had 1 year of, like, mark the calendar, regular periods, or 2 years of any periods, that's one of our definitions that approximates the end of growth. So if we've controlled the curve and kept it below surgical magnitude into that time frame, that's a good thing. Boys, we don't have that physiological thing to keep track of. There might be a case where
Shoe sizes, are they still changing?
we look at some armpits. I like to ask families, I go, is deodorant optional? Oh no, not deodorant. He needs deodorant 3 times a day. And so, and the height assessment, as Dr. Urse correctly points out, is also super important. Once a patient has gone beyond what we refer to as peak height velocity, they're on the downhill slope, and then their risk of significant progression is much lower. There's also certain radiographic things that we look at. There's a growth area on the top of the pelvic bone that we keep track of in particular. There's some special hand x-rays that can help us make estimates. And these can become very serious for some kids. Do we need to brace you? Yes or no? Do we consider you high risk versus lower? When do we stop bracing? When is there light at the end of the tunnel? And
So maybe it's a good time
to
to point out what the brace would do.
Yep.
Because we're trying to do a couple things. One is see, do we need to do anything?
Yep.
2, we're at a kind of a risk of progression. So let's slow it down. A brace may help hold the spine a little straighter.
Yeah, that was my question. What
and
do
then,
you do?
And then we also would be doing monitoring 6 months every year.
Yep.
You would do another x-ray and say, is this getting worse, or are we kind of reining this in?
Correct.
It's not advancing in degrees. Remember, 30 goes to 58. Dr. Mehlman's antennas go up a little.
That's a big deal.
And then, the brace maybe isn't doing the job. So show us how this looks a little lighter than the old faster ones, right?
Is that a body brace?
So I brought one of the scoliosis. This is for a very small person with idiopathic scoliosis to make it more convenient for us. But this is what's commonly referred to as a TLSO, a thoracolumbar spinal orthosis, which sort of squeezes you a bit like a tube of toothpaste. And there's pads are placed at key areas. You want to push on the rib that corresponds to the apex of the curve, usually in the thoracic area, and then usually another pad in the lumbar area. And they've shown that kids that are reasonably thin, another newsflash, if a kid is profoundly obese, the braces have been shown to be less effective because they're pushing more on the body fat and less on the curve. But there used to be questions about whether bracing was effective. And those were largely put to rest by a large NIH-funded randomized trial that we participated in called the BRACED study, BRAIST. And the treatment effect of bracing to prevent progression and to prevent surgery was so profound that it became unethical for a patient to randomize to observation. They stopped the trial early because of how bracing was shown to be effective. And what that works out to is about properly worn, it's about an 80% chance of preventing surgery, which is the most important outcome that is.
And how
important
often
to
do they
patients.
have to wear the brace? Is it most of the time except for showers, or these are
Yep.
waterproof and little Cindy's going to struggle through it?
Back at the beginning of my, back when I was Dr. Urse's resident and at the beginning of my practice, it was 23 out of 24 hours. So you had 1 hour a day to take your shower
For a year?
and do something. Yeah, often 4 years. Now that's gotten better. So routinely, many, if not most, pediatric orthopedic surgeons who take care for scoliosis would give them 4 hours out. So 20 hours in, 4 hours out. That's a little more leeway for them to do some of those.
Time to go to the
Yep.
time to go to the gym and not look funny, because I'm sure that has a certain psychological issue with some girls and adolescents.
When I went to school, there was, back in the 60s, it was like
Here it
these
comes.
rods that came up around your head.
And so that's a brace. I like to overstate and say all of us had at least one girl in our high. Even in my
She was the nicest girl ever.
Even in my East Ohio redneck high school, we had one girl in this small school that had the brace you're talking about, which was the Milwaukee brace. That was the first widely prescribed and utilized brace made by doctors Blount and his orthotist in Milwaukee, Wisconsin. And that's still not a bad brace. But it was rather oppressive by today's standards, and it's tough. It's tough enough to get somebody to wear the brace you're holding.
Oh gosh, I couldn't imagine.
And those are changed yearly, probably for growth.
For growth, as it fits, exactly.
Okay.
The Velcro wears out, etc. And so we like to praise the kids, and there's a very significant psychological side, and you're praising the kid. They don't want to be that kid that has something weird that they have to wear differently. It's a tough time. Okay, I believe there's still group showers. Okay, after gym class. Okay, I don't know that there's private showers in all these schools, and so there's a big psychological side to it, and you have to really impress upon them that what you're trying to avoid is the biggest surgery of their life. The biggest of the surgery of their life would look like this. Okay, this is complete exposure of the upper thoracic all the way into the lumbar spine. And we try to encourage them to go to some of the YouTube sites where you can see this unfold. There's a certain smell to scoliosis surgery. I wish we could expose them to that. And that's just trying to impress them.
This podcast goes global, but the odors won't.
So you praise them for wearing this because you don't want them to go to
Correct.
that.
And we acknowledge that what we're asking them to do is difficult and not fun. We're asking them to be mature beyond their years. I pick on my daughter a little bit. When she was younger, in the early years in high school, she developed asthma bad enough that she was admitted for a short time to my own gosh darn hospital. And she was put in a situation where she had to be mature beyond her years and have her inhaler all the time. Asthma is a dangerous disease. It can kill you.
Oh, yeah.
Okay. And for a while, she was a knucklehead, okay, about remembering her inhaler. But she turned around and she matured and became more mature in her management of her disease. Similar analogy here for the kids to wear the brace as they could and should.
Wow, you show them that picture. That's a reason for her to wear that brace. I'm telling you.
But the teenage brain is still developing, and they think about this afternoon in class. Many would rather accept surgery, okay, instead of accept a brace. Oh no, and so that's hard for us to understand, especially when and literally that would be with virtually no other exceptions. That would be the biggest surgery of any human's life, is having your spine exposed like that.
Now, how many of those do you do?
Because what are you doing when you do it? You're decreasing that curvature
We're limbering
to
up.
improve future breathing, future pressure
Correct.
on the heart, and you're not making it perfectly straight, right? I mean,
Sometimes we get close,
Look at
okay,
you.
but not always. So we're limbering up as much as you can by removing the muscle attachments. You're going at the small little joints up and down the spine.
so if it's tight, you're loosening it.
Correct.
You're an orthopedic guy, right?
There's some pretty good chunks of cartilage come off those little joints. I said there must be some sad son of a gun with arthritis that could use that. And then using various instrumentation, things that get a grip on the spine, screws and hooks and wires and rods, it's brought around and straightened as much as we can safely is what that comes down to. But it's big surgery.
It's almost like the rods on a dollar sign. You're taking that S curve, and you're trying to straighten them out. And
there was a version of scoliosis instrumentation called the Harrington rod, where they did call it a dollar sign. It was what it would look like on an X-ray. Terry asked how many. There's about 200 to 250 kids a year at my hospital that have this operation.
And are you one of the surgeons that do this operation?
Exactly. We've done that for many, many, many years. Now we have 2 younger surgeons now that are doing the bulk. And so I'm at a stage almost 30 years in where those youngsters deserve a boost. And so that's what we've done for them recently.
And again, this might be something when school's out, right? You would maybe in the middle of the year, this is going to take a little nip out of the history learning, isn't it?
Dr. Urse is thinking like the dad that he is. Okay, everybody jockeys for Christmas vacation from school and then summer vacation.
Yeah.
Because the kids, we prepare them to miss between 4 to 6 weeks of school. Where this operation, even if for whatever reason we have failed, if we found it too late, if the brace, you can do everything right and the curve can still progress. But if we get to surgery, the kids are in the hospital usually about four days or less.
Right.
They usually miss about 4 weeks or so from school, and in a 4 to 6 month time frame, they'll be back to their normal activities. I've got collegiate cheerleaders who went back to doing their college cheerleading routines.
Wow, that's amazing.
Within that time frame, I have a very sweet Chillicothe, Ohio girl who was a barrel racer on horseback. I got her back racing on
My daughter
horses.
did that. It's pretty
that's a dangerous
Pretty
sport.
energetic.
That's a dangerous sport, yeah.
So that's what we're trying to avoid, though. We're trying to avoid the biggest surgery of their life.
So is there anything coming down the future that might help folks avoid this and maybe even avoid this? Is there anything coming that you can see down the pipeline?
My first answer is find it early and treat it early and avoid surgery.
Sure.
So the screening is the most important. As having taken some coursework in clinical epidemiology, that part of my training will never go away. I would like to find disease early. We have effective treatments. We have this type of brace that we looked at. There's also some French Canadians who invented an elastic type brace, which also, when we've studied it in our own center, this works at least. I used to say it works as good or as bad as traditional bracing.
Yeah.
But because it competes with the traditional bracing, I allow people to choose.
Will the insurance cover that one too?
Yes.
That looks so much more.
Many people choose this. Others, this one has a longer track record and has been studied more vigorously.
Yeah.
This one has now been around for the better part of 30 years. No brace works if it's in the closet. And there's all sorts of stories of kids getting up and saying, "Look, Mom, I got my brace on." And they go out the front door, going off to school. They go to the neighbor's house, take it off, go to school all day. There's a ton of stories like that.
It's got to be hard to convince them, right?
Sounds like a good time for GPS monitoring on braces.
And when we did the randomized trial, there was a heat monitor inside the brace, so they knew exactly how long 98.6 or thereabouts was being registered.
Oh,
so that was the first. It's one of the major studies to document compliance with how long they were true, what they said they were wearing versus really wearing it.
So, but in a kind of take-home points here,
right,
is this is a disease mostly of adolescence and growth.
Yep.
And when we're 18 and we're done growing, and probably earlier if you're a woman, you're going to really be at the end of growth for the most part of scoliosis problems, which may continue in adulthood with some issues or not.
Right.
But the the people that you find earlier do better because the treatment can initiate sooner, and you can hopefully delay some of the more serious treatment forms.
You can prevent curves from getting to a surgical magnitude. So as Dr. Urse mentioned, at least in passing earlier, around 50 degrees is the cutoff that really makes people talk about surgery. And if you creep into the higher 50s, hitting to 60, et cetera, that's a real case. Now,
and that's because lung function decreases, or
it's measurable. But the point here is that, like we talked about the creepy thing at the beginning when I showed you the crazy curve spine.
Oh, yeah.
That's what we want never to happen. We never want right-sided heart failure and shortening. So that's in the hundreds to 120. So curves can progress to that level. So it's a heck of a thing to call it a game, but the game of scoliosis is to prevent that from ever happening in the first place. And so that's why in a kid that still has growth, especially, if a curve gets to be about 50 or go a little bit over 50 degrees, the natural history, what will happen if you continue to do nothing, that curve will progress rather relentlessly in many cases. Not always all. There's still some caveats where you have to pay attention, but you're worried about relentless progression to the oh my God curve that we saw earlier.
So if somebody watching this as we wrap this podcast up, if they want to reach out to you, how do they find you?
For us in Cincinnati, it's easy. It would be cincinnatichildrens.org is our website. They should be able to get to that pretty easy.
Okay, so that's the best.
And
way.
again, this podcast goes outside the United States. So again, if you've got a child or if you've got somebody you're concerned with, a friend tells you about their child, get them in to see somebody. Every country, every area has regional experts. And again, this is not the average doctor's not going to have all the skills that someone like Dr. Mehlman has to tell you what the right thing to do is. So, again, simple things, prevention always helps, keeping ahead of the game in medicine.
Well, in that case, we're going to land this podcast right now. Dr. Mehlman, we want to thank you for joining us. I never knew any of this. This was just fascinating to me.
Dr. Urse, education has occurred.
That's right.
It has.
It's a rare thing with me.
Don't forget the Bone and Joint Playbook on your social media sites. Make sure you tell a friend. Like us if you got a little button in front of you, and tell some people that they can learn a lot about scoliosis by listening to really smart people like this.
That's right. But don't you want to thank your sponsors?
I do. Well, thank Ted's Greek Dressing. You can go to tedsaladressing.com. And we want to thank the GWR group, Stiefel, Nicholas, and the guys that are Brad, Guy and Jeff Richardson, who are great consultants for some of those future plans in the financial world.
All right. Well, thank you all for joining us. Dr. Mehlman,
Thank you
thanks
both.
again.
Appreciate it. Good to be
And
with
we'll
you.
see you again in a couple of weeks. Thanks. We're out.